We're about to start on our second and final day of this conference. I know yesterday was a full day and tiring. I thought that the wrap-up last night was a really nice and really good departure from our work. This morning and this afternoon we're going to do Aspergillus. We're going to cover Aspergillus and the other moles. And then the endemics in the afternoon. There'll be a sort of a lunch break, but nothing really planned over that time. And then we'll have a break from 5 to 7 this evening, and then we'll have a wrap-up dinner this evening where we'll do the reviews or the summaries of these discussions. So this is our agenda for the morning. For break at 10:30, that'll be preceded by 4 talks relating to Aspergillus and other moles. And then this afternoon, the endemic mycoses, the break, and then we'll have a working dinner, and then wrap-up comments. And my goal is to have us really done by 9 or 9:15. There's really no reason to drag this on, but there's a lot of material to cover, so I'll try to keep people on time today so that we can, get to these breaks, get a little rest, and get through the day efficiently again. So really, without any further ado, I'm going to turn the program over to Demetrius and Marissa. Where's Marissa? Oh, there she is. Okay, good. And if you guys would introduce the speakers, and then we'll go from there.
So we're going to start with the first speaker. Louis White is going to talk to us about Aspergillus diagnostics.
Good morning. It's a pleasure to be here, and thanks to the organizers for the invitation. So indeed, I'm going to talk about Aspergillus diagnostics. Now, I'm going to attempt to cover diagnosis of aspergillosis across the spectrum of disease, but keeping an eye on the time. So I may not cover everything in the detail that you may wish, so please feel free after the presentation, or actually during the break, to track me down and ask me any questions. So, every day we breathe in hundreds of Aspergillus spores. If you work in agriculture or you work in construction, you may actually breathe in thousands of spores. These, because of their small size and buoyancy, make their way to the distal alveolar spaces, where they are blocked generally by alveolar macrophages. If not, if they evade those macrophages, they're blocked by neutrophils, and generally disease is prevented. Now, we have a range of Aspergillus manifestations, as I've suggested. Now, dependent on your underlying condition of the patient, disease may present in a different manner. Obviously, you have the classical invasive pulmonary aspergillosis, where you have invasion of the tissue leading to angioinvasion, and that's driven by prolonged and profound neutropenia. And we have a time to sort of presentation of days, or just a few days, or maybe a week or so. We then have our invasive pulmonary aspergillosis without angioinvasion. Now, this occurs in our patients that may have a solid organ transplantation, maybe non-neutropenic, or sort of receiving steroids and things like that. And so what you get is invasion of the tissue within the lungs, which is invasive pulmonary aspergillosis, but you do not get the angioinvasion. And that has implications onto what tests we can actually use. You then have the chronic forms of disease that are represented by patients with underlying lung conditions such as cavities or COPD or CF. And then probably somewhere around here, which is not on this schematic, is our sort of allergic diseases and asthmatic diseases in patients suffering from underlying conditions like cystic fibrosis. Now, these underlying conditions have implications on what tests we can perform. And to be fair, it's probably only culture and microscopy that's been fully evaluated across all disease manifestations. PCR could possibly be applied to all these, but hasn't been fully validated really outside of the invasive aspergillosis setting. And generally what we're looking at is when you've got an allergic disease or sort of an asthmatic disease moving into some of the chronic presentations, we're looking at antibody detection. And then for the invasive aspergillosis diseases, we're looking at sort of the antigens, including beta-glucan and that, although some of the chronic pulmonary aspergillosis manifestations can be used with antigens and PCR as well. So our reference standard remains culture from a sterile site, or histology or microscopic evidence of fungal elements in tissue. It's not particularly sensitive, but the reason it remains the reference test is the high specificity. So pretty much if you culture from a sterile site or you see fungal elements on microscopy, you're guaranteeing proven fungal infection. And that's important in clinical trials. So in relation to culture, every microbiology lab performs culture, obviously. Benefits, it can be applied to a wide range of specimens, and it's got a broad detection range. I've avoided using a pan-fungal detection range there because, as many of you will know, we can't really detect pneumocystis by culture in a fashion that would be useful in a diagnostic laboratory. And other fungi, such as Malassezia, require things like lipid-rich formulas. We do have an isolate available for further testing, which is useful. Obviously, you're going to perform identification, but you also may want to perform susceptibility testing. But in outbreak situations, when you've got clusters, it's useful to have an isolate to perform typing. That can be limited if you don't have an organism, you're relying on molecular methods direct from specimens. It can also be used for next generation sequencing, for sort of evolutionary studies, and then for looking for genetic markers of resistance. Limitations are sensitivity. Now the 50% I've got in the parentheses there represent an optimistic recovery of Aspergillus from respiratory specimens. In my setting in Cardiff, when we did an audit from 2005 to 2010, from our proven probable cases of aspergillosis, our recovery from culture or by culture was less than 20%. So in that situation, it's not very good for excluding disease. And you also have the turnaround time, which could be anything up to a few weeks to actually, basically to exclude whether you're going to get something. And the other issue is that if you wait 2 to 3 weeks with a plate that's capable of growing fungi, you leave it for that long, you may well end up getting contaminants on the plate after that period of time. So one thing that is often overlooked is optimization of culture. Now, in the UK, we have a national protocol for processing respiratory samples, which is if you have a sputum sample, you add sputers all in 1-to-1 to make it easier to process. You then do a 1 in 500 dilution, and you plate 1 microliter. Now, this is designed for the recovery of bacteria from the specimen. It's not designed for the recovery of fungi. And if you plate 1 microliter or 10 up to 100 microliters, you don't really recover much in the way of moulds. If you take out this dilution factor and then start plating larger volumes, you can see the recovery of moulds increases. But if you're really, really dedicated, more so if your lab staff are really, really dedicated, and they're happy to cut out the chunky bit of the sputum, which my lab staff I know wouldn't do, and then plate that directly, you can really improve the recovery of moulds. But generally, that's not going to happen in practice. Particularly in sort of microbiology settings where the BAL sample is quite often processed by bacteriology staff rather than dedicated mycology staff. You also need to cover or consider here media composition. Now, there was a media called Media B+, that was developed by Nagano et al. In 2008. And it's quite a simple media containing glucose, peptone, and yeast extract. And what they did is they then added 5 antibacterial agents to this media. And what they showed, there was a great improvement in the recovery of fungi from respiratory specimens. This was then followed up by a study by Jacques Meis in the Netherlands, looking at the recovery of moulds from his CF population. And by using this media, there was a massive increase in the number of moulds recovered in terms of numbers and in terms of the diversity of moulds. One of the problems you could have with this process is it's very nutrient rich. So when we've tried it, our fungi do not sporulate, which then has implications in terms of identification of that fungi. We have to transfer it over to a SAB plate to get identification or to assist identification. In terms of microscopy, obviously benefits again, wide range of specimens, part of culture ID, broad detection range, and unlike culture, it is rapid. Limitations for conventional sensitivity, limited differentiation. Obviously, Aspergillus from the hyaline molds, but even sort of Aspergillus from sort of the phaeohyphomycosis can be difficult when you've actually got stained tissue. Also, from a situation when you're looking at tissue, you may have hyphae that are overlapping each other. So where you may be expecting a fungi that doesn't have septa and doesn't have sort of 45-degree branching angles, you may end up with artifacts that look like that because you have hyphae growing over the top. You no longer have an isolate for adjunctive testing, and it requires an experienced operative to actually analyse and interpret sort of the images you're going to see. Recommendations are to use optical brightness, such as calcifluor, and if you're doing histology, you should use silver stains and PAS. The British Society for Medical Mycology recommend that even if this is done by a histologist, the actual slides should be then examined by an experienced medical mycologist before any result is actually given. So on to biomarkers. That's what I'm basically going to discuss over the next few slides, and they provide potentially with rapid results, potentially with high sensitivity and specificity, but the performance may be restricted to certain cohorts. Obviously, you get false positives and false negatives, and you can get variable performance, even though you're dealing sometimes with an assay such as the galactomannan analyzer, which has been generally just one manufacturer for most of the time. So you'll all be aware of the galactomannan analyzer. I'm not going to spend too much time on this test because all this should be quite familiar to most of you in the room. Just to say, it is recommended in guidelines, and it is the first FDA clinical biomarker for aspergillosis, meaning that if you want to enroll patients, you can do if they are galactomannan positive. Beta-D-glucan, again, a lot of this information should be familiar to most of you. It actually works on the system that we're activating factor G of this, basically the clotting cascade of the horseshoe crab, which is an immune response in the horseshoe crab. In the Western Hemisphere, we were, up until recently, just working with one beta-D-glucan kit, the Associates at Cape Cod Fungitel. There's now definitely two available. The Dynamica kit is available, and I think there's a third one that's actually just been launched and is available in the Western Hemisphere. But outside of the Fungitel, there's limited evidence on performance. Here, you should really only test serum or plasma, and I'll discuss why you should test BAL in a few later slides. So, despite having limited data on utility, i.e. how patients are managed when you've got a result, they still are recommended in guidelines. And quite recently in the UK, the NICE guidelines recommended that if you had a negative beta-D-glucan result, that was sufficient to exclude fungal disease in your patient. Now, I sort of agree with it, but being a bit of a geek, a bit of a nerd, I like stats. And so I think the stats really, when you go beyond a negative predictive value and you look at negative likelihood ratios, they actually contradict what they're actually saying in those guidelines. Molecular tests, again, are rapid, and they have a broad detection range. And outside of culture, they're really the only test that can be truly pan-fungal when designed to be so. They can be highly sensitive and highly specific if they're optimized to perform and well designed. They also have the ability to detect mutations associated with antifungal resistance, but I'm not going to go into too much detail on that. That will be covered by speakers who will follow me in this session. And they can be multiplexed. Limitations, specialist equipment and training, the expense of doing the test, and we will get, like with the other biomarkers, we will get false positives and false negatives. Now, they're slightly different to what we see with sort of the antigen and beta-D-glucan testing. We can have false positive results associated with molecular reagents. Generally, these false positives are associated with DNA from other fungi more so than DNA from Aspergillus. However, the Aspergillus DNA has been found in nucleosens lysis buffer, which is part of the Biomary automated extraction process. And they've also been found in silica, basically, which is used to pack QIAGEN spin columns. So you can get Aspergillus DNA contamination. More worryingly so, they are found, DNA from Aspergillus is found in sodium citrate vacuotaners. And that is because citric acid is produced in industry by Aspergillus niger. And that is then used to make the sodium citrate that goes into your vacutainers. So you must never use a sodium citrate vacutainer if you're performing Aspergillus PCR. To a lesser extent, you may see some lower rates of contamination in EDTA vacutainers. Now, there are questions over standardization, which I'll address in a few slides, and then commercial options. But that has then prevented PCR being included in guidelines to date. This table represents some of the commercial assays that are now available for Aspergillus PCR. What you can see is they've been used to basically test BAL and serum plasma, but performance is quite variable. But we do need to take into account that the Fungal PCR Initiative, of I'm a member of which, has shown that DNA extraction is rate limiting. And many of these studies will have not followed the international recommendations, or the international recommendations were not available for these studies to follow. So we need to basically readdress the performance of these tests when using the International Fungal PCR Initiative recommendations. And for instance, the Pathognostics Aspergillus assay that we did an evaluation in Cardiff following the recommendations, and doing so we did have optimal performance in terms of sensitivity and specificity when following recommendations. In terms of biomarker performance, you have to consider what you're using a test for. If you're doing a high-frequency screening test, you're basically trying to exclude fungal disease. And so namely, you need a high sensitivity and a high negative predictive value. And it's beneficial for low incidence diseases, of which aspergillosis is generally one. So what we have here are the meta-analyses of galactomannan, beta-D-glucan, and PCR for the detection of invasive aspergillosis. And what you can see is that the sensitivity of PCR is greater than that of both beta-D-glucan and galactomannan. The specificity is less, so overall, we find comparable performance despite limited standardization of PCR. But the sensitivity gives you a negative likelihood ratio of 0.15, which the authors of the meta-analyses said that negative results were then sufficient to exclude invasive aspergillosis. What about the situation where you would want to do a one-off sample, just a one-off isolated test? In that situation, you would not test blood. Positivity is very, very low if you just take an isolated sample for PCR testing. In that situation, you're really trying to perform some sort of confirmation. You've got a symptomatic patient and you're trying to confirm, does this patient have aspergillosis? In that setting, you need to get a BAL. And here we're relying on high specificity and a high positive predictive value. And you can see in the meta-analyses here of galactomannan and PCR that the specificity of PCR is greater than that of galactomannan. And so overall, performance is comparable because the sensitivity of galactomannan is slightly higher than that of PCR. Nevertheless, the positive likelihood ratio is greater than 10. So this pretty much means that if you get a positive PCR result in a BAL, it confirms the diagnosis of invasive aspergillosis. Beta-D-glucan is not on the slide because the specificity is so heavily compromised when you start testing respiratory samples because of the presence of commensals, such as Candida, or other colonizers which contain beta-D-glucan. Combined molecular testing with combined molecular serology testing looks to be the way forward for invasive aspergillosis in the hematology setting. These are two randomized controlled trials, one from Spain and one from sort of Australia. And this one looked at PCR and ELISA versus ELISA, and this one then looked at PCR and ELISA compared to histology, a CT scan, and BAL. And what they found was that basically, using the combined approach, there was an earlier diagnosis and a reduction in unnecessary antifungal therapy. Now, in the one study, there was an increase in the incidence of proven probable aspergillosis. But this was because they were using more sensitive tests. In the other arm of the study, based on conventional testing, they did actually perform the galactomannan and PCR test, but they withhold the results. When they retrospectively analysed that data, the actual incidence rates were the same in both arms. Interestingly, in the study of Aguado, the incidence of proven probable disease was actually reduced by using a combined ELISA and PCR approach. And they hypothesized that they were actually getting in preempting overt disease as would be defined by the EORTC MSG criteria. And another interesting factor is that mortality rate in the Aguado study was also reduced because they were acting in a preemptive manner, not waiting for overt disease before they implemented antifungal therapy. In a meta-analysis of looking at the performance of combined galactomannan and PCR provided a sensitivity and a specificity of now on 100%, meaning that when both tests are negative, you can exclude disease, and when both tests are positive, you can pretty much guarantee disease. So there are various combinations of how we can basically approach invasive aspergillosis. We can screen, where we have frequent testing, and then if any test is positive, you can consider introducing antifungal therapy, but only while you do a diagnostic workup. If they are then negative, you would then stop that therapy if you started it, or not even prescribe it if you hadn't. If it was positive, then you would continue, or you would then introduce it. You can also go down a diagnostic-driven route, which includes fever, here, where you would test blood, but ideally this BAL would also come up here, because I would recommend testing the BAL if you're trying to confirm disease. And you then, if positive, you would potentially start empiric therapy, or preemptive therapy rather, and then go on and do further investigations. Or you can rely on what was introduced in the 1980s, which is empiric therapy. And I think, to be honest, the improvements in diagnostics mean we shouldn't really be relying on empiric therapy anymore. In terms of standardization of PCR, a lot has been done in relation to Aspergillus PCR. And one of the things we've done is looked at the analytical specificity of testing. By analytical specificity, I mean the number of Aspergillus species that a PCR assay can detect, and also the number of other species or other genera that Aspergillus PCRs actually pick up by mistake. And so we distributed Aspergillus DNA to various centres across the world who were performing Aspergillus PCR. And what we found is the sensitivity of Aspergillus PCR methods were better at picking up Aspergillus fumigatus, as you would expect. When it came to the other assays, or the other species, there was a major reduction in the detection of by Aspergillus PCR assays. One interesting thing was Aspergillus lentulus, which is closely related to fumigatus, at the higher concentration had a high positivity rate, but when we went to the low concentration, the positivity rate fell away dramatically. But concerningly is if you look at the low concentration here, which is a concentration we would typically see in blood specimens, all species other than fumigatus are below a 50% positivity rate, which is of concern. In terms of cross-reactivity, as you'd expect, highest rates of cross-reactivity were with Penicillium species. But we also saw some cross-reactivity with Fusarium species as well. So the recommendations were that as PCR is probably better used as a screening test reliant on high sensitivity, we were happy to accept a degree of compromise to analytical specificity. So we put forward that if you were going to perform Aspergillus PCR, you should use an Aspergillus genus-specific PCR targeting the ribosomal RNA genes, because those genes are multi-copy within the genome of Aspergillus. We also have recommendations for testing of whole blood, serum and plasma. I'm not going to go through them today because they are widely available. These are open access publications. If you just search for the European Aspergillus PCR Initiative, put my name in, you'll come up with all of these. But what we did find was that nucleic acid extraction is the critical step. Most PCR assays, when well designed, perform to a similar standard. It is the extraction process, how much sample you put in, how much the DNA is eluted in, which is critical. And we're currently finalising analysis on BAL testing. We also did some work with Tom Patterson's group, the IAM group, to look at dynamics of release. And with the guinea pig model, where we performed Aspergillus PCR on serum and whole blood, and the IAM group did galactomannan and beta-D-glucan on serum. And what we found was PCR was an early indicator of disease. 1 hour after exposure, we had positivity in blood. This isn't infection. It takes 4 hours for the organism to germinate. Interestingly, the antigens were a good indicator of disease progression. As disease progressed, the index for the galactomannan and the beta-D-glucan concentration increased. But what we found was combination testing was required. And by combining PCR with galactomannan and beta-D-glucan, we could both confirm and exclude disease. The impact of standardization was assessed by an independent group where they performed a meta-analysis, and they found both the sensitivity and specificity of PCR methods following the recommendation was improved. Ongoing work, We're developing an international PCR standard in line with standards for HIV and Hep C, which will allow us to compare PCR assays without the need for an individual test. And we're also involved in 2 randomized controlled trials. Aspergillus PCR is now going to be recommended as a mycological criterion in the second revision of the URTC MSG criteria. Diagnosis of invasive aspergillosis in the ICU. I'm going to skip through some of these slides. One thing is that the incidence is very, very low, so you could question why do we bother trying to test for it, because it is so low. But one of the reasons is, if you look at the drivers of antifungal therapy in patients on ICU, it is pretty much signs and symptoms, whether they have a host factor, and the severity of the disease. When you do have investigations like biopsy and CT scan, etc., it's good when they're positive, but when they're negative, pretty much 50% of patients still receive antifungal therapy. But the take-home message was the diagnostic uptake was very, very low. For PCR and BTD glucan, it was less than 1%. And overall, there was no difference in mortality, whether they prescribed antifungal therapy or not in patients that were colonized or whether they had invasive aspergillosis. So what we're doing in ICU doesn't actually work. I think what we need to actually do in the ICU setting is actually rely on BTD glucan or testing of BAL specimens. And this study here shows you that the BTD glucan when tested in serum is a 90% sensitivity, which is comparable to BAL tested in galactomannan. They're also good prognostic markers that if they become, or basically if there's a reduction within the first 2 weeks, there's a better chance of clinical response and a better chance of survival at 6 and 12 weeks. And negativity in the first 2 weeks, which could be seen as a bad thing because they are false negative results, actually means the disease hasn't basically disseminated as thoroughly as it would have if they were positive and you had biomarkers in the blood. So they were also associated with survival. Molecular diagnosis has shown to also be useful in the ICU setting. Pediatrics, variable performance by the meta-analyses. And this has led to biomarkers not being recommended in recent guidelines. And there's an effort to actually address this. And this has been done, well, we're just starting to do this by a clinical trial by Bill Steinbach. And unfortunately, Bill's not here to sort of discuss this further. Chronic aspergillosis, you need to be performing Aspergillus IgG testing. Both the ESCWID guidelines and the IDSA guidelines recommend IgG for both excluding and confirming disease. And this is some work by the Manchester group, which actually shows you that most Aspergillus IgG tests perform to a similar standard. We also need to update our CF ABPA guidelines. They were first published in 2003. We haven't had anything since. And what you'll find, there's quite a few variables. Whoops, go back one. There's quite a few variables here, and the number of outcomes doesn't actually match the number of that we should actually have. So what about the other combinations, and what about the other disease manifestations in CF? So some work was done by the Manchester group, and I'm not saying this is an ideal situation or the ideal solution, where they've done PCR and galactomannan on sputum, they've then done IgG and IgE for Aspergillus and total IgE, and they've put a combination to do a latent classification. But at least it's a step forward in the right direction. Further considerations, we've got the lateral flow devices, and you can see that the testing of the BAL with the lateral flow of the CE-marked assay is fairly good, not so good in serum, and that combination testing with PCR has shown to provide 100% sensitivity and specificity. We also have the urine lateral flow device, already mentioned today, and the EME galactomannan lateral flow device, which will be interesting to see how they work in coming years. I'm just going to finish now in some work we've just recently published from Cardiff, where we're trying to predict aspergillosis, and it follows on nicely from invasive candidal disease, the discussions we were having yesterday. So what we looked at is 320 patients with hematologic patients, 54 with aspergillosis, and 270 that didn't have disease. And we combined clinical risk with genetics and biomarkers. And what we looked for were genetic risk in C-type lectin receptors in DC-SINE and DECTIN-1. These were previously associated with invasive aspergillosis. And these were commercially available assays, because we didn't want to have to go down the process of sequencing. And what we tested was the first and the last specimen from the patient. If that agreed, we were happy. But if there was a discrepancy, as you can see in this patient, we then tested the second and the penultimate sample to confirm there was a change. And then we then looked at the sample just after allogeneic stem cell transplantation. What we found, 41 patients actually switched profile. 22 had mutations introduced, of which 17 developed aspergillosis. 19 had mutations taken away by the donor, of which 5 developed the disease, which was a significant difference. So we then put a predictive model together, which looked at stem cell transplantation, mutations in DECTIN1 and DC sign, Aspergillus PCR positivity, and respiratory virus infection. And what we found, there was an optimal threshold of 3 factors, which generated a sensitivity of 70% and a specificity of 90%. Probability of IA in allogeneic stem cell was 64%. If you had less than 3 factors, the probability was 6%. So what we then found was that if we set a threshold of preemptive therapy being introduced at 50% probability of aspergillosis, 8.3% of our population would have been treated, which is still far less than what you would do through from an empirical route. One of the problems we had, this work was done on a patient population from about 10 years ago, and the number of allogeneic stem cell transplantations we're now doing is far more than this, and so this could actually creep up quite a lot. So concluding remarks is know your patient, know your cohort. This will determine the prevalence, and you should identify the risk factors and clinical symptoms to know how to understand your test. As Neil mentioned yesterday, will your results alter management? If it's not going to alter management, then why are you doing it? Combination testing is optimal, and antifungal resistance is coming, but I'll leave that to the following speakers. Thank you very much.
We have 4 minutes for questions.
Is that on? Yeah, thanks, Louis. I'm curious, how big a problem do you think it is that you've got a large body of people with possible disease in real life, and you really can't include these people in diagnostic test development and assessment because you don't really have a gold standard for knowing what's going on. So when you come up with these prediction models, and you're excluding those in devising the prediction model, what does that mean on the ground when you actually sort of implement them? Or is that just not really a problem?
I think it's a problem that can be better addressed by having more biomarkers available in the criteria. Because one of the issues you have at the moment is that it's pretty much just reliant on galactomannan. Because even with beta-glucan, you don't have invasive aspergillosis. You end up with probable invasive fungal disease. So from a clinical perspective, these possibles, in our setting, we find it less of an issue because we have PCR and we believe the PCR results. In our audit data, we had around 23 possible cases of invasive aspergillosis, by definition galactomannan negative. And then that leaves you with a quandary whether to treat or not. We found that 18 of those 23 were actually Aspergillus PCR positive. So we actually felt they were false negative galactomannans. And I think there's a bigger issue probably in relation to the guidelines, but not necessarily for the clinical sort of perspective, is when you have patients who don't have your typical radiology in terms of nodules, halos, cavities, but they may have non-specific chest x-rays, and then they have PCR and ELISA positive. We would treat those, but yet for clinical trials, they wouldn't get anywhere near a clinical trial, and they won't be defined as having invasive aspergillosis.
So, Lewis, thanks. So, I guess coming in and out of this community for the last 15 years, this problem feels sort of very sclerosed to me. And the sorts of things that you're talking about really don't have an impact upon my clinical practice where, I'd sort of fly blind most of the time. So I was just wondering about things like AI and machine learning to really have they been applied? They're starting to be applied, for example, for drug development, and they really turn up quite surprising and unusual links. And could those sort of techniques be applied to diagnostics for invasive aspergillosis?
Did you say AI, artificial intelligence? Yeah. Well, in relation to our predictive modeling, it's not sort of, it is artificial intelligence, but it's more sort of application technology. And I think what we're looking at is something to do with, the Framingham heart disease predictor, which is something online. You can go in, and then if you're a male, then you're going to have heart disease, basically, it tells you. So what we were looking at with our sort of predictive model is we would put that into an app which would then come into the situation where it would take all your risk factors together along with your biomarkers and give you a probability of disease. So I think it's not quite AI, but it's getting towards making, it's going beyond odds ratios, which I think are of no use in the clinic, and it's giving a probability of disease. And so we are in an individual situation where we're giving personalized medicine, which I think is required, because a lot of these individuals they are similar to a degree, but there's slight differences in why some develop a disease and some don't develop a disease. And we need sort of artificial intelligence to put all these combinations together. Otherwise, you're never going to make use of it.